Thank you so much. Thank you, Dr. Seema. And on this important day, I really feel blessed that ma'am has given me this opportunity to share this day, to share this very important day with all of us. And I would be talking on OCPs, and I will not waste much time because we have another very, very important speaker. We have Dr. Jatin who would be talking, and always we are always eager to listen to Dr. Jatin. So this is a very basic topic that, in fact, Dr. Sharda Jain ma'am asked me to take up. And thank you, ma'am, because I could read so much because of taking up this particular topic. So the important
Jyoti ma'am, we
would
like to welcome our experts also, ma'am. So I would like to welcome Dr. Jyoti Agarwal, ma'am. Dr. Jyoti Bali, ma'am. Is she here? Then Dr. Abha Sood and Dr. Sunita Arora.
Dr. Megha, you're not audible at all.
Yes, ma'am. Now I am audible.
Yes.
Experts, Dr. Jyoti Agarwal, ma'am, who is Senior Consultant and Director, Life Care Center and Life Care IVF. Dr. Jyoti Bali, ma'am, who is Director, Baby Soon IVF Center. Dr. Abha Sood, ma'am, who is associated with Jaipur Golden Hospital as Senior Consultant and Head of the Department. And Dr. Sunita Arora, ma'am, who is the Consultant Fortis La Femme and Specialist IVF. So, and we welcome our chairpersons, Dr. Sharda Jain, ma'am, and Dr. Brigadier R.K. Sharma. Welcome, ma'am and sir.
Second speaker of the day, I think Dr. Jatin has also joined. So I think Dr. Jatin can receive. So Dr. Jatin, we are very proud to welcome you this day. The day is very important for all of us, as well as we are very lucky to have you in this platform, and we are really looking forward to learn from you. Sir is a very known figure in AI. And practice of IVF from 25 years, and he has delivered innumerable international and national presentation, and he has really won many awards like Dr. Adi Award, Dr. Indumati Javri Award, and Dr. C.N. Purindre Award, and top doctors of Mumbai. So great of you, sir, to give us the time, and really we will be very lucky, and we'll be really enriched with your knowledge, and we'll be looking forward for further association with you in this infertility update. And DGF family will really welcome you, and with the sincere request that we please keep showering your blessings on us. And he is a founder member of Aspire and many other societies, and now he'll be member of our infertility update also. So we welcome you, sir, with a full heart and with full members, and on account of all the members of infertility update, I really welcome you. Now, I'll request Dr. Jyoti Malik to start her lecture on OCPs in IVF.
Thank you, Dr. Seema, and thank you, my chairpersons, Dr. Jyoti Agarwal, Dr. Jyoti Bali, Dr. Abha Sood, and Dr. Sunita Arora. And I thank Dr. Sharda Jain, ma'am, and Brigadier Sharma, sir, for giving me this opportunity to speak here in this August gathering. So I would be talking on OCPs in ART, and the thing that why we be giving a pre-treatment, and does hormone pre-treatment improve the efficacy and safeties of ovarian stimulation? So that is the key question that we have today. And why does pre-treatment, what does it do? Actually, the pre-treatment therapy suppresses or reduces the LH and FSH secretion prior to gonadotrophin stimulations. And how does it help before IVF is that it will synchronize the follicular development. So we have a good cohort of the follicles when we start our gonadotrophins, and we do not get asynchronous development. Some follicles are big, larger, and some are smaller. So this is the most important thing that all these pre-IVF treatments do. And they prevent the occurrence of early large follicles, they prevent spontaneous LH surge, reduce ovarian cyst formations, and very important is that we can schedule our IVF cycles. It is for our benefit, or for the clinicians, for the people working in the lab, for our patients. We can all in advance, we can plan our IVF cycles. It also allows us to plan the IVF activity in the next coming weeks or months, and we can avoid working on the weekends or the holidays. So it also allows aligning of the donor and the recipient cycles, and batch IVF that we were just now speaking of. That batch IVF is very, very common, very prevalent sort of a practice in India. And why is it so? And what exactly is it? What is a batch IVF? A batch IVF is an approach where the menstrual cycles of many women, of the multiple women that are being programmed, in such a way that they all undergo the same, all the processes at the same time, right? From the stimulation till the embryo transfer, it all goes together. And what it does it that we can align our infertility management with the logistics. Now, in batch IVF, the day for initiating the stimulation is calculated retrospectively from the scheduled day of the pickup. That means the day we have a consulting embryologist, since we don't have so many embryologists available in India, and people do keep going from one center to the other. Though with the new bill coming in now, each ART center has to have their own in-house embryologist. So maybe the batch IVF sort of practice will maybe fade off with time. But till that time, we have, till the embryologist, we plan everything, we schedule everything according to the date that we have of the consulting embryologist and the consulting clinician. And from that scheduled day of pickup, we go retrospectively and we calculate when we have to start the gonadotrophins, or when we have to start the agonists, and when we stop the OC pills. So what it does is it optimizes the usage of resources. We can optimize the drugs, the media, the consumables. But the disadvantage is that we have so much of work being piled up on those particular few days. So we have overutilization of the incubators, we have overwork for the embryologists doing so many Cs, and we have so many embryo transfers piled up for the clinicians right from morning to night. So that is the disadvantage. But how we can do pre-treatment? OCPs was a very has been tried in the past for so many decades, and now estrogen, progestogen, and the GnRH antagonists are also have been tried. So this is for the benefit of house, how we start doing, how we batch the whole program in the long agonist protocol was that if we consider day 0 as the day of pickup, when we have the in-house embryologist available, then from that day, we go backwards. So this is the day 2 or day 3, or maybe in case we do a blast transfer, the day 5 where we would do the embryo transfers, and day 0 would be the day of pickup, and day -2 is the day of the trigger. And from this date, we have been going backwards, and we have been doing our calculation as to on the day of minus day 11 or -12, we start the stimulation. And -21 is when we start the agonist. So that is for the long agonist protocol that was being done very popularly by most of our clinicians. Though now many of them have gone on to the antagonist protocols. And this is the important day, that is the day -17 when we stop the OC pills. So the OC pills get stopped for all the patients on day 17, -17, so that most of them start getting their menses around the same day. But in antagonist cycle planning, the treatment becomes more difficult because we are starting the stimulation on day 2 or day 3 of the menses, and the retrieval or the embryo transfer may sometimes fall on a weekend. So can the pre-treatment be done to avoid this? And does it affect the follicular growth? Does it affect the hormonal profile or the number of oocytes obtained? We will be discussing in the next few slides. So this is a batch in vitro fertilization with the antagonist protocol. How it is being done is it is similar to what we have been doing in the agonist protocol. But here we have not started the agonist. Here we have the OC pre-treatment being given, and then we give a 5-day washout period. So this period is very, very important. So this 5-day washout period, why is it important? So that would be, I'll come on later. So this is the time when we start the gonadotrophins. This is the time when we start the antagonists, and here we give the trigger. So everything here in the batch, we are going and calculating backwards. So in this comparative randomized trial that was done in 2006, they wanted to know the impact of the oral contraceptive pre-treatment on the follicular growth and hormonal profiles. And there they took that in terms of the follicular growth and the profiles, the OC scheduled antagonist regime mimicked the agonist regime. So it is something similar. We are doing the same thing in the agonist as well as in the scheduled antagonist, and when compared to the non-scheduled antagonist, that means here we are not giving the pre-treatment. So what was the difference? So in the OC scheduled antag and the long protocol, the pituitary suppression was more profound. So they found that the suppression was more profound at the start of stimulation. There was a slower start of follicular growth, longer stimulation was required, and more recombinant FSH was used. Now, what about the number of oocytes? So in all these three groups, the number of oocytes was similar, and as well as the number of good quality embryos was also similar. So in the number of oocytes and the good and the quality, there was not much difference between the pre-treated and the treated group. So OC pre-treatment prior to the recombinant FSH and Generelix regime, it could be successfully applied to schedule the patients, though more stimulation days and more recombinant FSH was required. Now, another paper in the same very year, they also studied and they said that definitely on the day when if the pre-treatment has been given, it results in significantly lower starting FSH, LH, and E2 levels and a thinner endometrium. And here they found that the group pre-treated with OCs, there was a prevention of the endogenous FSH rise, and there was improved follicular homogeneity. So the follicular cohort was very much homogeneous. This resulted in more oocytes. So they found that the previous group felt that there was not much difference in the oocytes number, but they found more oocyte number in their study. So as a consequence of that, they found that the recombinant FSH required was much more in this pre-treatment group. So a study done in 2017 by Farquhar, he found that in the protocol with the COC pre-treatment, the rate of live birth and the ongoing pregnancy was lower than in the non-pre-treatment, and there was no evidence of difference in the OHS rates or the number of oocytes. And all in the cases of poor responders also, there was no difference in the pregnancy rates or the number of oocytes. And but this another RCT, which was that was done in 2018, they had 140 women where they compared the COC pre-treatment of 10 days with no pre-treatment in the anti-protocol, and they reported no difference in the clinical pregnancy rates or the mature oocytes rate, and no cases of OHSS occurred in their study. So what does the ESHRE recommendation say? That a COC pre-treatment of 12 to 28 days is not recommended in the ANTAG protocol because of the reduced efficacy. So that was what the whole recommendation suggested. But this was a moderate quality evidence of a lower live birth or ongoing pregnancy rate using COC pre-treatment in the anti-protocol compared with the no pre-treatment group. And the type of COC treatment in these studies was heterogeneous. So that was another negative point to the whole study, was that some people used it from day 12 to 18. So the duration in some studies was not was variable. In some, the duration was fixed. And another important was that the heterogeneity between the studies was the washout period between the stop of the COC pre-treatment and the start of the stimulation. So this was another thing which could have affected the rates, and this may have had an important impact on the hormonal environment. The washout period of or the minimum days when after which the stimulation was started. Now, it is also important to note, however, that the available evidence comes predominantly from the recombinant FSH stimulation in these protocols and the usage of ethinyl estradiol combined either with levonorgestrel or desogestrel. So these were the basic two salts in the OC pills that were studied. And whether a negative COCP effect exists in other treatment protocols or when we are using other COCs is not known. Now, coming on to estradiol pre-treatment, I've spoken to you about the OCPs. What about estradiol pre-treatment? Now, estradiol pre-treatment is also becoming quite popular these days, and this is being administered from the mid-luteal phase. That means post-ovulation after 7 days of that, or when we are expecting at least 5 days before the expected date of the next menses, and it is given in a dose of 2 mg twice a day for a maximum of 10 days. And what is characteristic and to be noted here is that we have to have a gap of 1 day after the last dose of E2, and stimulation can be started after the 1 day of the last dose of E2, and that is the 1 day washout period is good enough for this regime. So this is the different which makes it unique from the OCPs, the estrogen pre-treatment. And this Cochrane meta-analysis of the estrogen pre-treatment, what does it say about the live birth rate and the pregnancy rate is that when estrogen pre-treatment was compared with no pre-treatment in the antagonist protocols, there was no difference between the live birth or the ongoing pregnancy or the clinical pregnancy rates. And this one I don't know what has happened. I'll just share my screen again. So significantly now in this with the estrogen pre-treatment, they found more oocytes were retrieved in the group treated with estrogen compared to no intervention. This was again the study by Farquhar, and that he felt that there were in fact with estrogen he got more oocytes in the treated group. And another very fair recent another RCT included 140 women comparing the estrogen pre-treatment with no pre-treatment, and they in fact reported no significant difference in the clinical pregnancy or the oocytes retrieved. So we have had different studies are giving us different results. Some feel that they have got better oocytes retrieved, more number of mature oocytes. They had better pregnancy, but the others claim that there is not much difference. And the recommendation by ESHRE suggests that pre-treatment with estrogen before ovarian stimulation using the anti-protocol is probably not recommended for improving the efficacy and safety. Now, progestogen, does it differ from the OCPs and the estrogen pre-treatment? The progestogen pre-treatment again is something similar to the OCPs, and again we have to give a 5-day washout period here. So in these cities where they had 421 women where progestogen pre-treatment was compared to no intervention, they found no difference in the live birth or the ongoing pregnancy rates, and there was insufficient evidence to determine whether there was a difference. That was in the agonist protocol, no difference, but insufficient evidence according to them in the anti protocol. And there was insufficient evidence to determine whether pre-treatment resulted in a difference between the groups in the mean number of oocytes retrieved in both agonist as well as the antagonist protocols. So comparing the three, if we compare the progestogen, if we compare estrogen and norethistron, and so in the anti-protocol, if we compare these three, what is the difference? OCPs in these study in this particular paper was started on cycle day 2 or 3, given for 15 to 21 days. Progesterone was given for 10 to 15 days from day 15, and estradiol was given from 2 mg twice a day, started 10 days before the presumed menses. And in the OCP and progesterone, they found that the FSH-LH on day 5 corresponded with day 3 of the spontaneous cycle. There was a difference in size of antral follicle was much lesser as compared to the estrogen and the control. And in the estrogen, there was no significant suppression of FSH and LH. So estrogen does not suppress the FSH and LH so much as the oral contraceptive pills and the progesterone does. And that is why we have to give a 5-day washout period when we compare it to the estrogen. And a comparable outcome in terms of the retrieved oocytes, the pregnancy rates, and the live baby was found in all these 3 groups. So a minimum of 5-day withdrawal period is suggested during OCP and progesterone pretreatment, and shorter withdrawal period for estradiol pretreatment for optimum outcomes prior to initiating stimulation is suggested. Now, what does our ESHRE recommends regarding the pre-treatment with progesterone? They say that it is probably not recommended for improving the efficacy and safety, and the GDG acknowledges that estrogen or progesterone are widely used for scheduling, and this is acceptable probably because it is safe, and given the data on efficacy and safety, it goes well with that. A word about antagonist pre-treatment as well. I'm sure Dr. Jatin Shah will his opinion as well there. So what about the antag pre-treatments? One small RCTs in 69 normogonadotrophic women reported no difference in ongoing pregnancy and the number of oocytes, comparing the early follicular pretreatment with the antagonist compared to no pretreatment in the fixed antagonist protocol. So this is in the delayed start protocol or the fixed antagonist protocol. There was not much difference found in both pregnancy rate or the number of oocytes. And a small RCT including 60 Bologna poor responders showed no difference in clinical pregnancy or retrieved oocytes comparing the delayed start with the conventional start protocol. And the ESHRE recommends that GnRH antagonist pre-treatment before stimulation in a delayed start protocol is probably not recommended. So coming on to the washout period, but after both OCPs and progesterone, the endocrine profile shifted from strongly suppressed FSH-LH values to values similar to those observed in the spontaneous cycle, while the follicle size also in the cohort remained homogeneous. And therefore, these results suggest that a 5-day washout period is optimal for these patients being pre-treated with progestogen and OCPs. In contrast, the natural estrogen pre-treatment did not significantly reduce the FSH levels, and follicle size within the cohort appeared as heterogeneous as observed on the spontaneous cycle day 3. And moreover, the abrupt FSH rebound after stopping estrogen intake with a concomitant increase in follicle size argues for a short washout interval of 1 or 2 days. And the Cochrane review also done in 2017, they found that among women undergoing stimulation in antagonist protocols, COC pretreatment was associated with a lower rate of live birth or ongoing pregnancy than no pretreatment. And in the adverse effects, they found that except that progesterone pretreatment may reduce the risk of ovarian cysts in the agonist cycle, and the COCP may reduce the risk of pregnancy losses compared to no pretreatment. So this was also a fairly recent paper in 2018 where they compared pretreatment either with OCPs or estradiol versus no pretreatment, and they found no significant difference in the oocyte, mature oocyte, the endometrial thickness, or the embryo quality. And the pregnancy rate in the E2 group was higher than the other two groups. And but the difference was not statistically significant. So the type of OCP, does it matter? The OCP administration here, they found that are there any difference in the fresh and the cumulative live birth of women undergoing controlled stimulation following pretreatment with different type of OCP. So here they considered ethinyl estradiol with besogestrel, the third generation progesterone, and the second one was drospirenone, which was a fourth generation progestin. So these were the two progesterone salts that were studied here. And with the OCP administration for an interval of 12 to 30 day treatment period and with a 5-day washout period does not affect the clinical pregnancy or the live birth rate in women undergoing stimulation. So to summarize, with the OCP pre-treatment, the pituitary suppression is more profound. There is slower start of growth, longer stimulation is needed, more FSH is used. Though some studies say that the number of oocyte retrieved is similar, few studies say that the oocyte retrieved is better and is more, and the number of good quality embryos is similar. But there is definitely improved follicular homogeneity, and if we go by that, it would automatically sort of convert into more oocytes when we have a follicular homogeneous cohort there. And with the estradiol pre-treatment, the FSH levels start to rise after 2 days. So we give a washout period of 1 day is kept. There's no difference in the live birth or the ongoing pregnancies, though more oocytes are retrieved. With the progesterone, there is no difference in live birth or ongoing pregnancy, and there's insufficient evidence to demonstrate the difference in the oocytes retrieved. With the GnRH antag pre-treatment, no difference in ongoing pregnancy or the number of oocytes retrieved, and a minimum of 5-day washout period as has been stressed in the OCPs and progesterone pre-treatment, and a shorter withdrawal with the estrogen pre-treatment for optimum outcomes is suggested. So life is like trying out things to see if they work, and we keep trying different things so we can someday come to some conclusion and to a consensus. So over to the chairpersons for further comments.
Wonderful lecture, Dr. Jyoti. I must congratulate. It is wonderfully given, and a very boring topic has been made so interesting and so elaborate and very interesting. Now I request all the experts, Dr. Sharda ma'am first, and then Dr. Sharma sir, to give their comments.
Today I'm going to keep quiet because, whatever ideas I've learned from Brigadier Sharma. And I find, Jatin Shah, whether he knows it or not, I definitely admire him. And it is on my request that he is here. I think, what I will want everybody to share what are they doing it. And then we will ask Brigadier Sharma and Jatin Shah to sum up before they say. So the experts to share their own, what are they doing in their own practice. Not to share what is being practiced by anybody else. Everything is as she has crystallized. So I think let's hear from the experts. Dr. Jyoti Agarwal.
Good afternoon, everyone. Very nice presentation, Dr. Jyoti Malik. As far as my OCP use is concerned in ART, most of the cycles that we are doing at our center, almost 99% are end-tag cycles. And we are not using any OCP as a pre-treatment in these patients. We used to use OCPs when we were doing agonist cycles. So more or less, and we neurologist in town, so we are not even batching the patients. We are doing as and when patient comes, and we are not giving them any OCPs. Other uses of OCPs, we are even sometimes in PCOS patients when we need to wait for the FET cycle and we want them to be silenced slightly, then we use, and not OCPs, but estrogen and progesterone we are definitely using for the HRT preparation in FET cycles. This is what is our experience. And if we start the stimulation early by day 2 instead of day 3, the crop is more or less similar. The later we start, more difference comes in the crop.
Jyoti Bali and Dr. Sunita Arora, ma'am. Your opinion?
Dr. Bali, please. Madam Arora. Dr. Bali, boliye.
And my experience with OCPIL, I'm not very fond till nowadays. Am I audible, Dr. Seema?
Yes, madam.
Yes, ma'am.
Yes. So earlier it was like, OCPIL was in trend and I used to give it for pre-treatment in almost all my patients. But for the last 2 years, I have stopped using OCPIL for pre-treatment in IVF unless there is a cyst, a simple ovarian cyst, which I need to resolve. Or on, day 2, in day 2, day 3 itself, there is lot of incoherence in the follicle, or you can say a residual cyst of the last cycle. That's the only situation where I'm using high dose OCPIL. I make sure that the dose which I'm using has got around maximum 30 to 20 micrograms of ethynyl estradiol. This is what I prefer, and the number of days also not more than 15 to 20 days, if at all, for some reason. And as Dr. Jyoti Agarwal just mentioned that, this HRT preparation. So this is one situation where I'm using it for FET cycle for because HRT is the way I'm preparing my patients for FET cycles. So in a prior month, when I give a Lupron shot also for most of my patients, there I use OCPIL. But most of the times, OCPIL as a routine for pre-treatment is almost out for me now. This is all what I want to say. Dr. Jyoti Bali.
Hi, ma'am. I think I have always used OCP for pre-treatment because earlier when we started working, it was batching of IVF done in the unit. So there we were using, and now in my own practice also, I think it helps me, getting rid of a cyst. It is for sure that the patient doesn't face disappointment on day 2. Am I audible?
Now.
Yeah. So I have been using OCP even till date and avoiding of a cyst, and then of course all follicles fall in line. It is down regulated to quite a degree, PCOS patients also, and I am very fond of using OCPs even till date. And timing of the cycles also is convenient in the clinic.
Thank you.
The cohort is in place then when you start stimulation on day 2, and most of the protocols are antagonist protocols, 95% and above.
Dr. Sharma, sir.
Yeah, thank you. I think all the speaker and the experts have summed up the whole thing. The one thing is that we are not using OCPILs blanketly for all our patients. It is only in the selective group of patients where you'll be using OCPILs. And now what the indications which they have brought out, there's a remnant cyst of the previous cycle, or the patient. Another 2-3 indications which I'd like to add, where you may have to give OCPILs is, the patient of having endometrioma and PCOS together. Now here you are planning to give long protocol. And, in those patients, you may have to give, DNRH long agonist as well as OC pills. And then from day 21, you start your short-acting agonist and continue with that. And that for patients of endometriosis with PCO. And second is, when you get patients from outside, like many centers, in Delhi and otherwise also, there's patients may not be from Delhi or, from the local city. They may be coming from outside, and especially in our setup, because, the army background patients, they're still coming to me. They are posted somewhere else. They come to me. So I tell them to take OC pills of a cycle prior to that and come to me by day 21 to day 23. So that, their time is not wasted. Otherwise, if there is some follicle previous cycle remaining, so they can't get leave again and again. They'll have to go back. So similarly, any patient who's coming from outside your station, there also there'll be an indication of giving the OC pill to them. And the other indication, is when you have the batch IVF, which possibly, I think times to come, it is going to go now with the new rules and regulations. So my point of view is, if there's a remnant follicle of the previous cycle, when you do the day 2, and you can't tell the patient, okay, you come next day 2, and then next day 2 again, you find that the follicle is the remnant present. So under those circumstances, you may give the OC pill and, plan your stimulation next cycle, and call them on day 21 of that cycle to see that your OC pills have suppressed that follicle. And if not, then maybe you add the agonist and then see them on day 2 and then start the stimulation. Patients of endometrioma with the PCO, long protocol where you want to give it there, I would like to give OC pills. And then outpatient, from the outside the city, if they're coming for IVF, and those patients possibly a cycle of OC pills before they come, so that they don't go back again. It's difficult for them to take leave again and again.
Thank you very much, sir. Thank you. Any questions from the house?
Dr. Jatin,